Okay. And please make sure, that you're muted when you come in. Because this is a little bit of a bigger group, we ask that if you have any questions to hold them until the end of the presentation, and we'll be more than happy to answer your questions at that point. You can always put in the chat, but we will answer it at the end rather than during the presentation. Okay. All right, so I'm going to share my screen. Great. Okay, so as I said, this workshop will be on the role of counseling in the overdose crisis, and it will be presented with myself and Bernd. I am a registered clinical counselor, and I have a master's in counseling psychology. I've been involved in research around the overdose crisis for the last few years. Bernd, if you want to introduce yourself as well. Oh, you're muted.
Yeah, hi. So I'm Bernd Mueller, and I am a registered social worker and working as a psychotherapist in private practice. And yeah, have been involved over the past, 12 years here in and around Vancouver with the population experiencing substance use concerns and trauma.
And so before we start, just want to acknowledge that this workshop is being presented by Bernd and I on the traditional, ancestral, and unceded territories of Squamish and Coquitlam First Nations peoples. And my pronouns are she, her, and Bernd are he, him. If you would like to add your pronouns, you can go click on the participant icon at the bottom of the Zoom, and then when you hover over your name, there should be an option that says more, and you can rename your name with your pronouns in it. Okay, so to get started, I think it only makes sense to kind of, start this workshop with noting the number of overdoses. This has been talked about earlier today by our keynote speakers, but I think it's just important to kind of highlight it again. So the map that I have here is from the latest Canadian report, which was from January to September 2020. And there has been 1,646 overdose deaths between April and June 2020, and then 1,705 deaths between July and September 2020. And so this has been the highest quarterly count since they started counting these numbers back in 2016 when it was declared a public health crisis. And it's also 120% increase in deaths compared to the same quarter in 2019. And in terms of, BC, Western Canada, especially BC, has been hit the hardest with this crisis, where there are 6 people dying per day right now in 2020. And, as Dr. Krause talked about earlier, the COVID pandemic has definitely negatively impacted the overdose crisis, because people have been using more alone due to social distancing guidelines and closure of resources, as well as,
how's it going?
Oh.
Okay.
Sorry, if you could mute yourself.
Yeah, the thing is, I have them online because you.
Okay. And so, so there has been a shift to the drug market in Canada because of the pandemic, and this has been negatively impacting individuals who use drugs. So then the question is, what have we been doing about this crisis? I took this image from the federal government's website. And as you can see, they have a list of many different initiatives that have been put in place. So there has been an increase in investment in improving access to medication-assisted treatments like methadone, increasing number of harm reduction resources like supervised injection sites, Also investing in educational material, as well as, tightening laws and guidelines around opioid use. And, while all of these initiatives have been really important and they have saved lives, the number of overdose deaths have kind of more or less stayed the same or have increased since 2016, which is, a really grim reality. That, even though it's been 5 years since this has been declared a public health crisis, not much has changed. So really, is enough being done, and what more can we do? And so I think it's really important to kind of take a step back and look at this issue by considering the context of individuals, because we know that substance use is usually just a surface scratch of a very deep-seated problem. We know that low socioeconomic status has an impact on different parts of an individual's life, and one of those being drug use and the problems that lead to this and come as a result of this, like limited employment, education, increased violence and conflict. And this picture is very simplistic, and it doesn't really show all the other parts, such as racism and generational trauma. That is a big part of why we have part of this overdose crisis that we're dealing with. So I think, and what I'm trying to say with this slide is that substance use isn't just about someone using more substances they should. That can be fixed, by prescribing them some medication or controlling how much doctors prescribe opiates. It's a much more complex issue, which includes, social, biological, political, and psychological components. And we do know that there are, a very high rate of psychiatric comorbidity with substance use and substance use disorder. And so, in fact, research has actually shown that there's a strong association between early childhood trauma and later life substance use. So early childhood trauma is often measured using the adverse childhood events, which Bernd will talk a little bit more about later on. But this graph that I've included here is from 2 international meta-analyses that we looked at in a review, which examined the rate of childhood abuse and neglect. And as you can see, the substance use population, which is presented in the green yellowish color, has way higher reported rates of abuse and neglect in most areas compared to the general population, which is presented by the orange bar. And research has shown that those with traumatic childhood experiences are at a higher risk of developing complex concurrent disorders later in life. But the good news is that therapy can help, and it works for addressing concurrent disorders. For example, a meta-analysis found that therapy approaches that targeted both substance use and mental health, co-occurring mental health problems like trauma, effectively reduce trauma symptoms and substance use. So, this is pretty promising finding that I think should be given more attention by professional and policymakers, given the large proportion of reported childhood traumatic experiences among individuals who use drugs or have substance use disorder. So I think what I want to communicate with these slides that I presented is that the number of overdose deaths haven't been going down with the initiatives that we already have in place. So something else needs to happen, right? And integrated therapies that address both substance use and underlying mental health issues like PTSD, anxiety, and depression can help, because like I said, substance use is this complex issue, and it's not just about someone using or not using drug. It's not like really a personal choice, and we know that. Yet that's kind of the initiatives that have been put in place. Usually that's how they've been approaching this overdose crisis. And so, I'm not saying that therapy is the golden ticket to ending this crisis, but I think it's an avenue that has been ignored for too long. And with that, I'm going to pass it off to Bernd to talk a little bit more about the adverse childhood events and his approach and experiences working with individuals with substance use problems.
Yeah, thank you, Ava. Yeah, does talking make any sense? I sure hope so. And let's explore that a bit more in specific. So I would like to introduce a few treatment approaches that I found very helpful and that dance very nicely with each other. And this is also backed up by research to, yeah, maybe get into a conversation about improving healthcare by adding more proactively psychotherapy into the mix. Yeah, the idea of adverse childhood events is just noticing that this has a big impact on that there's a relationship between adverse childhood events and the three landmarks of opioid use, age of opioid initiation, injection, and lifetime overdose. And again, the chronic pain aspect cannot be underestimated, and we get to that as well in a moment. So again, the 10 categories, few of them Ava just mentioned. Maybe next slide. Thank you so much, Ava. And yeah, just for your reference, these are the ACE domains. And yeah, next slide again. There is tons of research done in the meantime. This association is not even a debate anymore. What is debatable is the outcomes out of these studies. It very rarely leads to an increase in psychotherapeutic offerings to the clients. Okay, and next slide, please. Yeah, and we can now. The idea is here working towards an integrative approach, responding to the overdose crisis here, the contribution of psychotherapy. And the next slide is the 4 approaches. I like to touch on seeking safety, mindfulness-based stress reduction, MBSR, eye movement desensitization reprocessing. There you have a mouthful. That's EMDR, and acceptance and commitment therapy, or ACT. And next slide, please. Seeking safety. And yeah, next slide. Developed in the early 90s by Lisa Najavitz. And finally, version published in 2002, and that is also the current manual that is where everything is still based on, written and evaluated on males, females, and across gender identities, specifically effective for vulnerable populations, including individuals experiencing homelessness within the criminal justice system, domestic violence, and veterans and military personnel experiencing PTSD. And clients can be in any level of care. That means outpatient, inpatient, residential, and they do not have to meet any criteria for PTSD or substance use. Next slide, please. So the key principles of seeking safety are safety as a priority of treatment, integrated treatment, a focus on ideals, and this is referring to value-based work, and we touch on that later within the ACT approach. And that also shows the overlap and how we can fuse and actually coordinate and collaborate with other treatment approaches as well. And 4 content areas: cognitive, behavioral, interpersonal, and case management. And the last one is attention to clinician processes. Next slide, please. So anyone can conduct seeking safety, does not require any specific degree, license, or certification. It's about present focused coping skills, has been successfully implemented by professionals of all sorts, including paraprofessionals, advocates, and peers. And I want to highlight peers here. This is also often an overlooked part of our system, like involving peers into our healthcare system. There's an amazing opportunity here as well to notice that this is very low threshold. No reported adverse events around seeking safety over the past 20 years, and training is available but not required. Okay, thank you. So evidence-based in terms of this model reports to co-occurring PTSD and substance use, and that should be substance use, not abuse, strongly supported by research. So the evidence includes pilot studies and studies addressing various populations and individual and group treatment. So this is another piece. So you don't have to launch a group to provide seeking safety. There can be an individual treatment measure as well. And again, high complex populations that are typically excluded from studies are also included in these studies. And there are about like 89 studies or so. They're all available. And we will provide that list with the slides that shows that seeking safety has been very effective around as I just already mentioned, individuals experiencing homelessness, substance use, and so forth. Okay, and moving on. So seeking safety these are the 25 treatment topics basically within the seeking safety manual. And seeking safety is designed to continually attend to both PTSD and substance use disorders. And both are treated at the same time by the same clinician. As this integrated model is in contrast with sequential models in which the client is treated for one disorder first and then the other. Each topic in seeking safety is independent from the others and can be conducted as a single session or over multiple sessions. There are no particular coping skills or topics that clients must master, but rather they can just choose within the manual, within the topic list, what provides them with the best support right now. And the treatment is flexible and allows clients to address their most important concerns. And the idea is here really responding to the population that is at risk of dropping out and clinicians burnout. So this is a population we often experience high burnout rates with clinicians. And so this seeking safety manual also, the seeking safety approach also encourages clinicians to remain inspired and interested in the work as well. So there's a whole section on that as well. Okay, next slide, please. Any group size is possible. It can be used alone or in combination with any other treatment. Flexible approach, abstinence approach, harm reduction, or controlled use. It's all possible. And it can be used with any other therapy, including EMDR. And again, I have personally, this is an anecdotal observation, made very positive experiences with this combination as well. Okay, and moving on. Seeking safety, present focus, not avoiding the past. The idea is that clients name their traumas as part of seeking safety and explore in depth how it impacts them in the present. But the key principle is headlines, not details, not going into detailed exploration of the trauma. So with having said that, this is classic stage 1 trauma work. Slide. Cost benefits, a government analysis indicates that seeking safety has and these are numbers, and this is something I quote from the study here, an 80% likelihood of benefit relative to cost. And there's a comparison between 23 substance use models, again, this would be substance use, not abuse, and higher than motivational interviewing, motivational enhancement therapy, or relapse prevention. And relapse prevention being the most popular model. And yeah, this is just the numbers here. So if you are in a leadership position and just still on seeking safety, if you're in a leadership position within your organization and you're looking for cost-effective ways to provide cutting-edge therapeutic services to your population, if you're looking also to find meaningful ways to get outreach workers involved, social workers, peers, nurses, I would suggest that this might be of interest for you. Okay, thank you. And so moving on. So mindfulness-based stress reduction. So that's MBSR. This is an 8-week program. It's evidence-based and secular. Next slide, please. So developed by Jon Kabat-Zinn in the 1970s. It's combining meditation, mindful movement, and exploration of patterns of thinking, feeling, and behavior, addressing physical and emotional pain and suffering. Next slide, please. So what is MBSR? And that's Jon Kabat-Zinn. MBSR is based on rigorous and systematic training in mindfulness, a form of meditation originally developed in the Buddhist traditions of Asia. Simply put, mindfulness is moment-to-moment, non-judgmental awareness. It is cultivated by purposefully paying attention to things we ordinarily never give a moment's thought to. It is a systematic approach to developing new kinds of agency, control, and wisdom in our lives, based on our inner capacity for paying attention and on the awareness, insight, and compassion that naturally arise from paying attention in specific ways. So next slide, please. The 8-week program always covers the same topics. This specific particular framing is provided by the Center of Mindfulness Studies in Toronto, and it includes here week 1, for example, introducing mindfulness meditation, doing, being. Second week would be then perception and knowing are different, and so forth. The idea is getting together for about 2.5 hours, and then going home with some work that can be done at home over the week, and then coming back, sharing the homework, and then moving on to the next chapter. And the relaxation exercises and the yoga can provide physical relief by releasing tension and improving circulation. But however, the main benefit here comes through changing the way you perceive and react to your pain. Many times our thoughts about our pain, physical pain and emotional pain, triggered by fear, are very negative. Thoughts like, this is killing me, I can't stand it, how long will this go on, cause us to feel worse. The idea here is that through meditation, we are able to separate our thoughts from the physical sensation and also from the emotional experience. And the experience is that this can dramatically change our level of suffering. Just moving on, next slide, please. So like this, dissecting one example, week 5, stress, mindful awareness and responding. So in this session, we would deepen our understanding of automatic stress reactions by exploring the possibility of bringing mindfulness to our stress reactions. You may notice how the stress emerges and how the stress is experienced in the body and in the mind, and how this change over time. So automatic ways of coping with stress are often learned in childhood or adolescence, and over time they become habitual patterns of behavior and thinking, and noticing how we manage the stress that has originally served us and no longer does this. So now it becomes maladaptive. And mindfulness presents different options for how to be in relationship with all experience, particularly with stress. And the formal meditation practice provides us with a context of observing, and coming to know our automatic reactions to what arises, and joy within the meditation, for example, feeling joy when the meditation is good or despair when it's bad, and we can watch these experiences come and go, witness our automatic reactions to them, and notice how these reactions further impact our state of mind and body. And this would be some topics that would introduce to these procedures here, understanding automatic stress reactions and bringing mindfulness to stress reaction. And next slide, please. So, and studies have shown that MBSR increases the pain tolerance, changes in positive mood, improves stress, anxiety scores, improvement in health-related quality of life in substance-dependent populations in addiction treatment. And next slide, please. And here we have the effects of mindfulness-based intervention components on mechanisms and outcomes within the treatment of addictive behaviors. And if you just go through one line here, so mindfulness-based intervention is using the body scan, for example, as a technique, moving into the mechanism of decreasing limbic reactivity, noticing the effect of reducing stress reactivity, and as a clinical outcome, decrease in distress. So this just as a little imagery, little chart to deepen these research outcomes. And next slide, please. And one element that's key, or like I said, central, there's everything in the combination is of course important, but the body scan is one element within MBSR, and that's paying attention to parts of the body and to physical sensations in a gradual sequence from head to toe or toe to head. That might include noticing general discomforts, pains and tension, and just staying with that and noticing how the pain experience shifts while we pay attention to certain areas of our body. And that usually takes around 30 minutes or 40 minutes within the MBSR framework. And it's usually applied to you lying down or or you sit in a comfortable chair and just going through the body. And the idea here is noticing that if we name it, we can tame it, as banal as it sounds, but moving into an increased awareness that if we look at things, that things will shift and potentially also go away. Okay, and then next slide, please. So here's a quote reflecting on present moment awareness. The idea here is like every moment is a new moment. And with each breath, we can welcome each other. Hello, this is a new moment. The other moment is already gone. So that's about letting go of the past and decrease worry about the future. And one way of looking at this is a concept called, that we could call like widening the container. And maybe the next slide, please. And this is nice imagery that I found very helpful that Beth Mulligan, one of my teachers, shared at one point during a silent retreat. And widening the container, you can understand that as a way, like, let's imagine you have a teaspoonful of salt and you put the salt into a glass of water. You drink the water and it's yucky. It tastes disgusting. You can barely drink it. And the salt is the suffering. Now you have another teaspoon of salt. The salt is the suffering, same size of teaspoon. You put it in a jug of water, a bit more diluted, but still it doesn't really taste well. Same teaspoon, same amount of salt. The salt is the suffering, is your suffering. You walk to the creek, put it into the stream. You go downstream and drink from the stream. Now you don't taste any salt any longer. And the idea here is that the suffering has not changed. And by all means, that's not a call for letting things go and happen. This is a call for social activism. This is a call for social justice. This is a call for trying what you can do about increasing your own well-being as well. And it's also acknowledging that sometimes the salt can't be kicked off the spoon. It's just there. And noticing, while we can't change the amount of suffering, we can change how we experience that pain by widening the container. And that's nothing else than increasing awareness that I have a container and noticing what widens the container as important components of that approach. Shifting the pain experience. Okay, moving on. And this is just another little piece on a reference to adverse childhood events, and we can just move on. And in the early years, when John Kabat-Zinn had his first clinics on MBSR, he shared observings on client Mary, and who was a part of the program, and basically to drive the point home that MBSR is addressing adverse health effects of trauma, such as stress in the body. And yeah, we can just click through them. This is a sleep graph going to sound sleep. The next one is a blood pressure measure, going back to a more normal blood pressure rate. And you can just move to the next slide. And moving on to the next slide, even this is like a pain chart, a typical pain chart, like at the beginning of treatment. This is where the pain areas would lie, and the next slide would then show us there's very little pain left. Although all medical treatments has been exhausted. The medical side of things was kind of didn't really know how to move on from there. So technically the pain has not really gone away, but the whole experience has shifted here. And mindful meditation, MBSR program leads to quite encouraging results here. Okay, so moving on to the next part, the next approach, eye movement desensitization reprocessing, EMDR. The next slide, please. So first published in '89 by Francine Shapiro, integrative psychotherapeutic approach compatible with all other big psychotherapy approaches, 8-phase protocol led by an information processing model guiding clinical practice in general, 3-pronged targets of processing. So we're addressing the past, that's touchstone experiences or single events, the present circumstances and internal external triggers, which is nothing else than present circumstances, being on probation at place of employment, can't get ahead financially, so forth. Internal, external triggers, nothing else than the smell of alcohol around you, upcoming exams, performance reviews, noises, everything like that. Future desired state, future imaginal template. And moving forward, the adaptive information processing model as a theoretical framework means that memory networks constitute the basis of our perceptions, attitudes, and behaviors. These memories consist of stored informations, such as sensory input, thoughts, emotions, and beliefs. Disturbing events, such as adverse childhood events, cause disruption in our information processing system, leaving associated sights, sounds, thoughts, or feelings unprocessed and subsequently dysfunctionally stored. And next slide, please, just highlighting adaptive versus maladaptive resolution. While I might stay in an adaptive framework where I could process everything and nothing gets stuck. So I might feel like I survived, I can learn from this, I'm fine as I am. So while the trauma response would be where I can't process what's happening, my frontal lobe goes offline, timekeeping goes offline, it's driving phobias, flashbacks, low self-esteem, irrational guilt, and so forth. And the next slide, please. So inherent in the adaptive information processing model, AIP is a psychological self-healing construct similar to the body's healing response to physical injury. So this goes as follows. So when something mildly disturbing happens, you may think about it, talk about it, process it. On the other hand, when a trauma occurs that is too large for the system to adequately process, it can become stuck, dysfunctionally stored in the central nervous system. Maladaptive responses such as flashbacks can be triggered by present events. And next part is then earlier life experience. No, just leave there, sorry. An earlier life experience sets the stage for later life strengths or problems. Information from earlier disturbing life events, that would be the touchstone experience, can be physiologically and dysfunctionally stored in the nervous system in state-specific form. And that means the negative cognitive belief and emotional and physical sensations the client experienced at the time of the traumatic event remain stored in the central nervous system, just as if the trauma is happening in the now. So your house burns down and 5 years later you smell the smell of the barbecue and your stress response is, it is the house that's burning down right now as if it just happened yesterday or in this very moment. Because again, there's no timestamp on the experience. Okay, and moving on. Dysfunction. So again, this is just, if you just focus here for a moment on embraces, on inappropriate developmental arrest, lack of power in the past, that's the dysfunctionally stored part. So that is a moment in time where we can refer to a younger self of us where the experience is stuck. And if we would have an adaptively stored memory realm, we would embrace an age-appropriate power in the present. As if we would notice it's a barbecue, it's not the house. While embraces an inappropriate developmental arrest would be it's arrested in time of the house burning down. And this is an opportunity to work with parts. And that's the next slide. So within the EMDR framework, I'm working with the internal family systems model as it is adapted by Janine Fisher. And this is just a reference. And again, I don't go into further depth here, but just for the next part, I just wanted to add the slide also for your reference, working with parts, integration of approach, and that would be the next slide. So while there's a part within us that is going on with normal life at all times, this is still there, it's still present. We have also a trauma-related part, and you might refer to that as a younger part that is with us in the room here with us. This might be the 5-year-old Bernd, the 12-year-old Bernd, the 15-year-old Bernd is in the same room here while I'm speaking. And these younger parts have their experiences and their coping experiences. And if things are adaptively processed, then yeah, they are fine and at ease. While maladaptive stored information might lead to, again, arrested development there, it gets stuck in time, and the reaction to a stressor will be on the 5-year-old will then drive the bus of the integrated adult self of today. And this task, the task of the therapist here, is to help the client to separate this confusing blend into separate entities here. Because what we often have that if we experience trauma, we believe when we get triggered, we lose it all. Everything is lost in the fire. And just coming to a point of, no, you're not losing everything in the fire. You still have a going on with life part here with you, but the trauma part is pretty real. This allows the client, from the stable perspective of the self, beginning constructive inner dialogues with their parts. And moving on. So the 8-phase model. This is, we start with history taking. Second is preparation, building resources. And that's important with any exposure therapy. And every trauma therapy is exposure therapy. This one as well. So 3 is the assessment. And within the assessment, I just want to highlight the negative cognition, the positive cognition. The idea here is negative cognition such as I am powerless as the key part of the suffering, not the event, but the self-cognition that emerged from the event. So the house burns down, and the self-cognition that might emerge from the event is the world is not a safe place, for example. And then stating the positive cognition. What would I rather say about myself today? For example, I am safe now, or yeah, I am accomplished, I'm capable. Other examples would be, I don't deserve love versus I deserve love, I can have love. I'm worthless, inadequate versus I'm worthy, I'm worthwhile. I'm not good enough versus I'm deserving, fine, okay, and so forth. Okay, and moving on. The 8-phase protocol he continued. The desensitization phase is then the processing phase. And 5 is installation of the positive cognition. Have you arrived? Because this is what we're changing. We're not changing the event, we're changing the outcome. And therein lies the magic. And therein lies also an opportunity to change the past because we change the outcome. I am safe now. I am loved now. Or I belong, or I know that I belong now. Body scan, again, there's a nice dance with other approaches here. And the closure is always either building a container if we interrupt the session, that can be done at any point, or we close the whole session, and re-evaluation is then picking up the session next round. Okay, and just moving forward with the next slide. This is just one piece that you might be aware of. Saccadic eye movement is a big part of EMDR, and I don't go further into that because there's, of course, big discussions about what is working with EMDR, what not. Alternative means atones, buzzers, taps. So I'm using all of them as well. Activation of information processing system, which processes the dysfunctionally stored material around a traumatic event. So that would be the headline why this is used. So next slide introduces to one example of how EMDR branches into specific treatment just for substance use. I just wanted to mention that the Detour protocol developed by AJ Popke, just for your reference. I have put it in here. Okay, we can just move on. Evidence-based patients or like clients with substance use disorder, significant improvements, post-traumatic symptoms, reduction in anxiety, reduction in overall psychopathological levels, changes in self-esteem, decrease of depressive symptoms. That's EMDR. Okay, and let's just see where we are here time-wise. Let's quickly touch on acceptance and commitment therapy. And just next slide, developed by Stephen Hayes in 1982. Objective, not elimination of difficult feelings, rather being present with them. Again, here's the mindfulness-based approach here, integrates scientific knowledge about contingencies, shape behavior, and verbal relations. Next slide, please. 6 principles here. I just picked the value clarification. If you go to the next slide, welcome to my office here. This is a little bit of a personal touch. This is a chart I would use in my office, and I left it handwritten. So that's the hexaflex. These are the 6 principles of ACT, and they call it. They turn it into like the concept of the hexaflex. If you dance the hexaflex, you get psychologically unstuck. And one part is living in proximity to your values. And just going 2 slides further ahead, Ava, if you don't mind, this one, yeah, exactly, in the next one. So this is one example how we could get to it. So we are value-based creatures, that's the assumption here, and our brains support meaningful involvement. So we distinguish values from goals. The values are the non-negotiables, and they're usually lasting and are around for a long time. Goals are more temporary and negotiable. So everything we do is according to values. So from the moment we get out of bed, that's the bed down there, we follow a sequence of sub-goals and goals just to get to our value. And the next slide, please. So if we have a clear view to our values and the options to get there, even if you don't get there in a day, but just having the option, that makes for a good day. And next slide, please. So if an obstacle arises, that's the horizontal line here above the sad face, we feel negative emotions. Subsequently, we need to either remove the obstacle or we move to an alternative goal because goals are negotiable. So that gets us back on track towards the value. And that's the next slide. So the whole idea is here, moving away from living on autopilot towards value-based decision-making. In other words, regaining control over our lives. The next slide, please. This is, again, value-based work, possible values, social connection, acceptance, self-acceptance, adventure, fairness, honesty. This is from my practice, what I came across a lot. with folks. Next slide, please. Research backs up ACT as an effective treatment, and with many of our client populations that we are discussing today. And that leads us into our last slides here. Research again, 12 is in combination with 12 steps very effective, for example, rather than just prevention work. And the next one is, again, the idea of now, if you put it all together, next slide, please, pathways to integration. So setting up seeking safety, MBSR, EMDR. So again, just notably, what are the costs? What are the involvements? Some of them are very low threshold, require almost no investment in training, like seeking safety or ACT, for example, which you can just pick up as a counselor, for example. While mindfulness-based stress reduction is about a 6 to 12 months process to get certified here. EMDR in a similar way, less time intensive, but require some training. The idea is at the same time, what is the staff population that we have accessible at our fingertips, and how can we make this an integral part? Is it worth supporting these projects? And then just closing up here, this is the former Congressman Al Franken with the last slide here, in his character Stuart Smalley, the self-help guru in Saturday Night Live. It's easier to put on slippers than to carpet the whole world. Question is, do we provide our clients with slippers? And if so, do they fit? Okay, thank you.
Thank you, Bernd. So now we can open up the floor for questions, comments, or anything that may have came up for you during the workshop, the presentation. I'm just going to look to see if there's any. You can always, put your comment or questions also in the chat. You don't need to unmute yourself. We welcome that, but if you're more comfortable, you can definitely put it in the chat and we can read it as well. I think we'll give people maybe a minute or two to see if they're typing up anything, and then if not, we can move on. Okay, so there's a question from Stephanie saying, is there any best practices for opioid-specific counseling treatment compared to other kinds of substance use? Bernd, do you have any insight on that?
So thank you so much. Good question, Stephanie. So I'm not aware of like a specific, like the best practice opioid-specific counseling treatments right now. Again, there is the idea is really to develop approaches that are already there. So the approaches that I was just introducing have been shown very effective with individuals using any kinds of substances, really. The problem is that historically a lot of lobby work and a lot of funding went into CBT and trials. So that's why these approaches that I just introduced are slightly less popular, but they're gaining momentum right now. So you might traditionally see like CBT is the first line of, and rightfully so. And there's a lot of good stuff in there, but it often falls flat when it comes to trauma because it is kind of avoiding of that whole area. But yeah, but that's a good question. The specific, really specific models, I'm not aware of it.
Thank you. And then there's another question asking from, it's from Dasha, saying, what is your opinion on providing EMDR to street entrenched at-risk youth? I've received pushback from doing so, stating clients need to be stable to a certain extent as EMDR can bring up a lot.
Yeah, and thank you for the question. Yeah, great. And again, rightfully so, again, there is always a risk of dissociation, and we need to be aware of that. The EMDR approach in itself is stage 1, stage 2, and stage 3 work, stage 2 being the processing work. So stage 1 work is crucial, is key. Seeking safety is the stage 1 work, and EMDR has the same container and resource development component. So it is important to keep the clients, as we would say, like in the window of tolerance, which means between hyperarousal and hypoarousal, that clients stay within that window, that re-traumatization doesn't take place. At the same time, once you get into the process of setting the stage with EMDR, you will quickly learn and know and how the client feels around certain events. It's not every event is the same, not every memory is the same. And there are also a lot of resourceful memories, resources that come up through history, taking positive events that also can be installed within the EMDR framework. And that's often overlooked when we just anecdotally refer to EMDR. So EMDR is also a great opportunity to use the EMDR technique to bring out resources and install resources. That wonderful memory that I had when I at the beach, or when I held my baby that moment, and that tuning into that and bringing up keywords and using the ability of the brain to bring up imagery that is perceived as if you would have experienced it in vivo. So I would always make the case, let's still start the program by maybe staying with resource building, but it would be called EMDR already.
Another question here from Morgan, which asks, what is your experience providing counseling immediately after an overdose? Does talking make sense?
Again, again, you can never really say talk for everyone, but in general, the idea is what just happened. So somebody is going through a crisis, something happened. And the idea is what worked in counseling, the main we have strong indicators that the therapeutic alliance is the most important and is a key driver for a successful therapeutic outcome, no matter what approach you're using. And what does it mean? If you use that research piece and translate it into your question, which is great, because we often don't do anything because we don't really know. We engage on a personal level, and that's nothing as what an outreach worker would do. And we would address someone who just overdosed. We would not just not talk to them. We would go and say, how are you doing? So is there something we can do for you? What keeps you calm right now, or safe? If safe is not an option, is there a calm place for you, and so forth. And as a therapist, you just do the same work. It also expands the concept of therapeutic work at some point. When do we call it therapy and when not? So maybe the outreach worker, then providing seeking safety, is then also the therapist, moving into that treatment realm by having a first contact and moving then into maybe a calmer place, like an office on a regular basis or so forth. Yeah, great question. Yeah, this is really important for all the overdose prevention sites. How can we deal with the incoming demand? Nice.
We have one more question from Heather, which asks, what approach would you suggest to engage high-risk individuals who may not be interested in treatment or changing their substance misuse? Example, people on probation.
Yeah, this is a great question. And what's really helpful here is really having the stages of change model in the back of our heads. That would be the pre-contemplation phase. That really precedes the contemplation phase. So should I make moves, should I not? And then moving into a preparation phase and an action phase, and then later on maintenance, while relapse is always an option at every stage of the phase, and you don't lose anything by relapsing. You're not going back to square one. Having that as an introductional piece here would be a great introduction to treatment options. So if you would have an opportunity to get into a calm place with that individual and introducing the 5 stages of change and just acknowledging, and this is basically using motivational interviewing, acknowledging where this client is coming from at the moment and noticing that every stage is a good stage. And this would be like in a traffic light system, you could approach it, okay, I notice you're at a red light on, let's say, specific treatment. What would move it to a flickering orangey light? We're not even talking green, we're not talking yellow, orangey flickering light. Is there anything that would move it to orange? And then there's often a smile, I don't know, but often that sets loose more options, because if you step back for a moment, what is the experience of someone who is in the criminal justice system? It's black and white binary system. It's all black and white. You're good or bad. You're in and out. You're off and on the team. But inviting dialectical thinking, like that supposedly opposing truths could be true at the same time. I can say, I want to live, I want to die. I hate you and I love you, that both is possible, provides options. So we're creating a space and a room, which therapy is, where we rest for a moment that is now witnessed by the therapist, so that the individual is not going through it alone anymore. And the individual can come back to that place at any time. And when we rest and when we look at a place and when we look at a place where that is calm, usually options emerge and choices emerge. And one way to introduce that would be, for example, the 5 stages on an emotional interviewing flow, and asking that any light is a good light, or any stage is a good stage. Yeah.
And we have one comment here from Hallie, which says, I've been using thought field therapy, TFT, in my practice, as financially I can afford EMDR training and have been seeing amazing results. Others may want to look into this avenue. Thank you, Hallie. Yeah. We're getting close to the hour mark. If people have more questions, we'll be happy to answer them in the next 8 minutes. Yeah, so please, unmute yourself or post it on the chat, and we can definitely answer them. Okay, well, it doesn't look like anything's coming in, so I think we can maybe call it a wrap. What do you think, Bernd? Is that, yeah?
Sorry. No, absolutely, yeah. And again, so everybody feel free to connect even after the session. And yeah, we will also provide the slides with all the references as well. And thank you so much for your time and taking this hour of your life to be part of this here and to observe, and for your mindfulness to engage in the moment. Thank you so much.
Thank you, everyone, for joining us. Hope you enjoy the rest of the conference as well.
Good. Thank you.